dealing with the current hurricane situation, whether it be in the Bahamas or Florida or moving up the coast. So last I heard, the hurricane was still moving at 1 mile per hour. So we're going to go ahead and get started today, and we're going to actually start with a celebration. We are really excited to announce that CMS has notified HRET that the HIIN project will be continuing through March 31st of 2020. So our team is very excited to be able to continue this partnership with you as you are improving care throughout Indiana, and we're excited to continue our partnership with HRET and ultimately with CMS. So with that, in the spirit of whoever has seen Paul McGann and others at CMS, they like to ring a cowbell, and I brought my cowbell in today, so I'm going to ring it real quick. Excitement that we really are thrilled and excited for this. So I think that's just really as part of, being part of Team Indiana, we have a lot to be thankful and grateful for. As you know, last month, Becky Hancock was actually that would have been in July. Into July. Becky represented us. Actually, when I say us, I mean the IHA team, as well as all 90-plus hospitals that are participating with us on this HIIN work, to receive a national award for our excellence in the work that we are doing with HIIN. So thank you for all that. We are currently planning our programming for the months of September through March. We've had, some planning meetings, and then with those 2 months that were kind of month to month, we didn't want to roll out a whole lot until we knew for sure what was going on with the HIIN contract. So be on the lookout for upcoming programming for the next 6 months. And I will just kind of pause there, too, and just say, if you have any suggestions or feedback on what we're doing well, what we could do better, please be sure to put those into the chat box. And then also we'll have some time at the end, too, where if you we'll open up lines, and if you want to share, what kind of feedback and programming that maybe could be specific for your hospital, something regionally or even statewide. We'd love to hear that input. I did want to point out, too, that the Encyclopedia of Measures has been updated. It is posted on the HRET HIIN website. And so you'll see one change that's noted. There are some measures that have been moved to optional, and that is the MRSA measure, MRSA, SSI that's tied to total knee, SSI tied to total hip, and then the harms events related to patient handling, as well as workplace violence. So I say that they're optional. We would certainly encourage you to go ahead and enter those, especially as we move to this next slide, showing our statewide improvement. In some of these areas, we have been showing improvement. They're actually not up here on the improvement calculator, because HRET has taken those measures off the calculator. But to continue our celebration here, I just want to show everyone our HIIN results through the month of April. And we say April, I know many of you have actually submitted data through May, but because readmissions is through April, that's where we haven't cut off our statewide improvement calculator. So there is a good number of measures that we have achieved. The anticoagulation safety measure for adverse drug events, the CAUTI in the ICU, both CLOPSI measures, falls with injury, SSI for the abdominal, and the CDIP measure, as well as in the ventilator-associated condition, actually the new measure that was added, the PVAP. So some great work. We're making some progress. I won't go through each one of the making progress, but certainly a couple of those that are, fairly close are getting there, especially like the opioid safety measures is close to that 20%. We do still have some great opportunities to make in sepsis, and that is, I guess, kind of timely, but it is Sepsis Awareness Month. So Becky's going to spend quite a bit of time today talking about sepsis. I will say that we have, while those say that our rates have gotten worse, when you could look back to like the previous month, some of those we actually have shown some improvement. So we do believe we're on the tipping point of making some great strides in even those measures that show that they are worse. And then, you know, and again, just to hit on those major opportunities, still have some opportunities with the IBAC and the BAC measure. MRSA, you know, that is, you know, again, a optional measure now, and they certainly continuing to do our work in readmissions, whether it be 30-day all-cause or 30-day Medicare. So again, great work. I think this dashboard keeps improving each month that we're looking at it, so we're really fired up to really see what it's going to look like when we show this at the end of March or even at the 1st of April of 2020. So with that, go ahead, Becky, if you could advance to the next slide. And I'm going to go ahead and turn it over to Becky Hancock, who is going to walk us through sepsis and Sepsis Awareness Month.
Good afternoon. This is Becky Hancock, and I'm going to turn it over to Casey a little bit. So she's done a tremendous amount of work with our sepsis toolkit for Sepsis Awareness Month. So we're going to cover all the resources, not all of them, rest assured. We'll hit the highlights and hit those toolkit highlights, do an explanation of sepsis data for the state and where we stand, and opportunities for how you can know your own data within and benchmarked against the nation as well, and identify some strategies for success with your sepsis mortality and your sepsis community and your sepsis hospital work. For starters here, we all know that sepsis, not all of us know, we're learning that Sepsis Awareness Month is the month of September, and that's the purpose of our outreach today. And what we've given you is an updated toolkit with social media outreach and community education. Of note is that Sepsis Awareness Day is officially September 13th. What we're asking for hospitals to do is to plan one community and one long-term care educational program in September. If you can't get to it in September and it's another time, that's really all right. But the whole idea is we want to improve community awareness so we can reduce time to treatment so the patients actually get to the ER so that we can address their sepsis cases. So there are many community and clinical resources within the toolkit that we're going to highlight. There are also patient and clinician-centered podcasts that we're going to share you here in a minute, and they are all available on our www.survivesepsis.com website that is here within IHA, and where you can download the toolkit and many, many resources. And I'm going to turn it over to Casey here, who has done some incredible graphics for this version of the sepsis toolkit, which is our 4th version thus far here at IHA.
Hi everybody, it's Casey. I'm hoping that you're all familiar with your sepsis toolkits that we sent out a few weeks ago, and hopefully you've made contact with your marketing people. They should have also gotten a link for the sepsis toolkit, and all of the imagery is new this year. We've updated, kind of refreshed the look, and added some messaging, especially around pediatrics and maternity. And we would like for, again, your marketing people are probably the most likely ones to be using your social media and updating your social media channels. So if you can get with them and make sure that they know it's a priority for HIIN hospitals to participate during Sepsis Awareness Month, we'd love to see these messages be shared. Also, something you personally can do is these messages are being shared on the IHA social media pages. So if you like IHA on Facebook, Twitter, LinkedIn, you can also like and share these messages personally as well as from your hospital, and that just spreads the message exponentially. Social media is a great way to get this awareness information out to people. I'm super excited to be on the chat because I got word from Andrea Kuntz at Community Bremen and from Jill at Greene County that they have both received their promotion giveaway materials today. So hopefully be looking today, tomorrow, the holiday threw things off a day, if you have ordered our giveaway boxes with toothbrushes, hand sanitizers, and first aid kit. Super excited that they let me know that those are arriving. So, and if you do not see them by the end of the week, please let me know. I have tracking numbers for everybody, so I should be able to find them. Also, as you do your community and your staff education events, please send me your pictures. We love to use those, share them on social media. We use them in toolkits for next year and other times that we're promoting sepsis awareness. We love to see what you all are doing. I also follow most of you on social media so that we can keep an eye, and as IHA, we'll like your sepsis posts as well. Something else to consider in your toolkits, we had sent a proclamation to Governor Holcomb, so he has declared that September 13th is Sepsis Awareness Day in Indiana. This is something that you might also consider doing. The template is in your toolkit on a local level, on a county level maybe. Also working with your marketing PR staff, consider a press release to the local media promoting September 13th as Sepsis Awareness Day. And I'm going to turn it back over to Becky to talk about our wonderful new podcast.
Yes, we're pretty excited about the podcast that we put together for Sepsis Awareness Month. They are 15 minutes or less, and they are varying topics based on the input we've received from one of our sepsis work groups within one of the coalitions. And what I did on this page was just to point which ones pair well together. First of all, we've got an overall one by Dr. Lindsay Weaver, who is an ER physician at IU Methodist Hospital, and it's Might My Infection Become Sepsis? And it is good for clinicians as well as patients about identifying when the infection is getting to an area that you need, a point that you need attention for it, and the risk factors associated with that, and also the signs and symptoms. So those are excellent for both. We put those on both sides. Some of the podcasts are well paired together. Dr. Kaiser from Columbus did a one on identifying sepsis bundle compliance opportunities, and we thought that would be paired well with Karen Kennedy's discussion about transitions in care and opportunities to improve sepsis care across the continuum. Good pairing. Also another good pairing is Casey Barnett from Terre Haute Regional did one for us on the Joint Commission sepsis certification that they have, and that addresses well with Lisa Bartlett's podcast on the experience of her husband who was not well identified in triage in the ED. And the pairing of two gives you the patient lived experience along with the clinical application of improvements to make in order to really emphasize with your staff what this means for patients and families as well. The third really good pairing is Suzanne Willis. These are all Hoosiers sharing their stories recently. Suzanne Willis had a sepsis experience and struggled with post-ICU or post-sepsis syndrome. And from that, we do know that there's research going on at Eskenazi for rehabilitation research related to ICU patients and their post-ICU psychosis following arrests. So Suzanne's story is the patient lived experience, and Dr. Bobber Khan's story is an explanation of the current research that will improve conditions for patients with post-sepsis syndrome as that progresses. The other two that we have that are exciting are, we were particularly asked to include pediatric sepsis recognition and pediatric sepsis treatment. Dr. Brian Wagers and Dr. Tyler Arnold from Riley gave us those podcasts, which are in the clinical podcast series. So I encourage you to pull these out, take a moment to listen to them, and share them with your staff.
And also, this is Casey again, on the patient-focused ones, starting tomorrow, I'm going to share the patient-focused ones on our social media pages. So again, that's a good way to engage the public through the social media to direct them towards the patient-focused podcast focused on patient education and recognition.
And I think one thing that does is raises awareness in the community to hear the stories of what's going on with sepsis. So that will a sense of urgency, I think, regarding time to treatment and knowledge and knowing the signs and symptoms of sepsis. Other toolkit resources, we separated them between clinical and community awareness toolkits, and just to highlight a few. The first one there on the top left is actually a patient-centered narrative in healthcare transitions. That is a discussion tool to use with Karen Kennedy's Lived Experience podcast, and it is to allow you to take a look at that podcast and identify any common issues and transitions in care that may be occurring within your facility that may be highlighted within this exemplary discussion of events that didn't progress in a way that was beneficial to the patient or the family, and this is a discussion group experience. On the left then we go to STEM school-age education. The Roy Staunton Foundation has age-specific K-2, 3 to 5, further up through K-12, specific STEM educational programs for kids around sepsis, and they're actually science experiments. And I did share these with the School Nurses Indiana State School Nurses Association, and they're just fabulous if you are a hospital that has close ties with your school nurses. Please share that specifically. I kept our 2018 clinical webinar series that we did last year, and one I wanted to point out was pneumonia prevention with oral care. And that's Dr. Joanne Brooks' presentation, and that's an hour-long webinar from last year. But the whole idea is pneumonia is the #1 cause of sepsis. And if we can prevent pneumonia by improved oral care, we can actually do a great job at reducing sepsis overall. So, and that's according to the ADA, American Dental Association's recommendation. But there's good data out there, and I encourage you to listen to that to understand how one hospital system reduced hospital-acquired pneumonias by 71% with their improvement efforts. On the right-hand side, back to community awareness tools and resources, there are table tents that can be printed so you can put out when you're doing a community awareness event, or you can actually use them in your hospitals on cardstock. There's a Sepsis 911 community education. That is from the Sepsis Alliance. And Sepsis Alliance has a combined webinar, specific content, pre- and post-tests for you to use out in the community. The webinar is very graphic, but it is a survivor of sepsis and her telling her lived experience, which is very, very motivating. So there are a number of other resources in there. I just wanted to highlight those, and then we'll keep an eye on the chat in case you have any questions or comments. And with that, what I want to move into now is how are we doing as a state around sepsis and sepsis mortality improvements. First of all, on the publicly available Hospital Compare website, it gets updated every quarter, and they have posted our state compliance by hospital with our sepsis bundles. And CMS has defined sepsis bundles as the Step 3 Surviving Critical Care Medicine Guidelines. And so what we see here on this graph is that we are, as a state, at 50% compliant with the sepsis bundles for the 4 quarters, fourth quarter 2017 through third quarter 2018. And that's a 1-year period. This is what's on Hospital Compare right now. And what happens is every quarter that gets 1 quarter added to it. It is really hard to move the dial when you're just adding 1 quarter at a time. So while we were at 50% compliant during that 1-year period, the nation is at 55%. And we really need to be over the nation. We want to keep moving forward on this. This does not have all the hospitals listed on, but what I really wanted to demonstrate is the majority of our hospitals are right now below the national average. Of course, we're at the average for Indiana. But anyway, we need to keep working on this. And I encourage you to know your sepsis data. Keep an eye on what's on Hospital Compare. The good news I do have is that for fourth quarter of 2018, fourth quarter of 2018, hospitals receive their quality net data, and they receive it in preview form before it's updated in Hospital Compare. What we know is that with this next update that goes out approximately first and end of October, we were at 56% compliant. Notice we were 50% before for that 3 quarters, and the nation was at 59%. So I'm happy to report that we are closing that gap, and I just want to encourage you to keep running the race. It's making a difference, and we'll get into more how we're seeing it making a difference as an association between the data points that we're getting there. So keep up the great work on improving your sepsis bundle compliance, and be aware of what yours is and know your resources across the state, and we're happy to help you get some mentors around you should that be necessary. So let's talk about HIIN now, how are we doing on HIIN? And with HIIN, our goal is to improve our metrics by 20%. And particularly within HIIN, the three metrics are post-op sepsis, hospital onset mortality, which is sepsis that occurs after they've arrived at the hospital, was not present on admission, and overall sepsis mortality. And overall sepsis mortality would include those who had it on admission through the ED, as well as those that had sepsis occurring later on during their admission. And what we see here is that our post-op sepsis rate is actually worsening right now at 2.16%, 2.2% essentially, compared to our baseline, which was the 1 year after we had implemented ICD-10, like from October of 2016, 15 to September of 2017, right before we got data here. Anyway, so post-op sepsis is 2% worse. Hospital onset sepsis mortality is 24% worse, and overall sepsis mortality is only 0.14% worse. We are making progress, particularly on overall sepsis mortality. We are moving forward on that, and I encourage you to keep running the race, like I said. Hospital onset sepsis mortality and post-op sepsis requires a little more fine-tuning regarding your screening for inpatients and implementing good sepsis treatment during inpatient identification of sepsis. So we're a little rocky on that, making progress, again, but biggest opportunity there with hospital onset sepsis mortality. Now I'm going to walk you through some of your data resources and how we look through HIIN's eyes right now and what your data resources are. And again, I encourage you to know your data. Don't have a hurricane coming at you and not know it's coming. You get plenty of notice, and here you can see your data over time. So be attentive, and as sepsis coordinators who are out there, it's up to you to know where your data sources are and work together with your quality directors. First of all, I'm going to show you your HIIN CDS data. On the left-hand side is how we're doing as a state with overall sepsis mortality. The green line is our target. The red line is our baseline. And as you can see, we are moving forward. There's peaks with flu season, of course, because of the flu patients who come in and get septic, and that's what you're seeing there in the peaks, but we are slowly inching down for overall sepsis mortality. We know that between 80 and 90% of our patients come in through the ED with sepsis, and that is probably where we're seeing the greatest impact because of improved sepsis screening in the ED. So keep up that great work. On the right-hand side is an example of what you can get out of the HIIN CDS data set. It's your quality directors. Every hospital has a HIIN key contact who has access to that database. And what we see here is an example from a hospital who has made tremendous progress in their overall sepsis mortality, resulting in a 57% decrease in their overall sepsis mortality by huge improvements in their sepsis bundle compliance, as well as a number of other inpatient processes that they're doing to focus on patient care. I will encourage you that one of the podcasts in there has highlights that are reflective of what should be done in order to improve care for the sepsis patient that I mentioned, so please be attentive there, but know your data. And here's what it looks like from the state as well as from one particular hospital, their HIIN hospital-specific data on overall sepsis mortality. The next HIIN metric is hospital onset sepsis mortality. And again, the target is in green and the baseline's in orange here. And what this shows is that we're really not progressing quite as much towards our target around hospital onset sepsis mortality. I know that all the hospitals are fervently working on their ED processes of screening, and again, this is back to our inpatient opportunities for hospital onset sepsis. I did mention one major opportunity for prevention is the pneumonia prevention by good oral care. That I still want to emphasize that that's an important process, but once you've got either concurrently or after you figure out how to do it properly in the ED, I encourage you to apply that process to your inpatient units with regular screening for your inpatients, because of all it's one of the harms that occurs that we've been sweeping under the rug and not paying attention to for a while. But anytime you're poking and prodding a patient and inserting lines and doing incisions, there's just the opportunity for infection to set on. So we need to be constantly vigilant about the risk of infection for patients simply because they walked in the door and they're around a different set of bacteria as well. our Indiana post-op sepsis HIIN data right here. As you can see, we are a little bit worse than at baseline on this one as well. And I encourage you to be attentive to your post-op sepsis patients. There are resources within the HIIN, HRAT-HIIN website around post-op sepsis including chart review tools and processes and checklists to pay attention to post-op sepsis. Checklists and gap analyses for you to do. I'm happy to walk any hospital through the post-op sepsis sprint that we did about 6 months ago and work with you on that if that is still an issue. But again, back to know your data and opportunities around your data. So that covers our HIIN opportunities and our HIIN data sources. I want to switch now for a moment to IHA's Data Link Tableau reporting. And Data Link is the name of our data resource where we have reporting that's coming out of our data services based on your inpatient discharge study that we pull HIIN data out of for several metrics, but also that data turns into reports that you can access. The current data Tableau reporting includes ARC indicators, and within the ARC indicators is your PSI data. It's specifically PSI for post-op sepsis, PSI 13. There are others as well as hospital-acquired conditions, overall mortality, readmissions, and then lastly, I'm going to dig down into the sepsis data link reports a little bit here. For sepsis, what we have is, and these are not new reports, we've had them out a few months, but what we do is we track two different things. We track sepsis mortality based on APR-DRG 720 and based on ICD-10 coding. The goal of APR-DRG 20, primarily that is patients who came into the hospital with sepsis. And what we see here is that overall, with all patients, we have gone in 2014 from 11.4% mortality rate down to a 9% mortality rate in 2019, and that includes palliative. So when you have palliative patients in there, that's not as quite as great of a change. But when you take the patients who had palliative applied to their processes out, we're actually down to 4.7% mortality in 2019, and that's really quite good. What we know is that with good sepsis care, you can get a mortality below 5%. Now, I will mention that overall, when we started this process, roughly in 2013-14, this shows 7% mortality rate. Some places it was up to 29%. The literature was showing overall mortality at 29% and for septic shock at 59%. So imagine the strides that we've made since this process began in 2014. Here's what we have by APR-DRG based on ICD-10 coding for primary or secondary sepsis codes. So it's harder to make progress when the diagnosis is primary or secondary sepsis because that's those secondary codes that occurred after they came in the hospital. And so what we're seeing is not a lot of progress here based on primary and secondary codes. But overall, when you take out the sepsis patients, we've gone from 6.6% in 2016 down to 5.4% in 2019. And this mirrors a little more what our HIIN data is being pulled from by ICD-10 codes. So that's why it's hard to make progress. But again, 80 to 90% of your patients are going to fall under the APR-DRG, and this is the overall, all the patients included. So how are we doing? Our volumes are going up for lots of reasons. Overall volume, you can see here on this particular slide, on the green teal colored line, you can see that we're going from 52,000 to 54,000 to 55,000, 2016 through 17, and we're on target to surpass that in 2019 given first quarter of 2019 data. But again, our sepsis volumes are increasing, which means we're identifying it more. But our mortality rates are decreasing, so that's a win-win for us. We're expecting to have improved screening, which we know we're experiencing. But again, we're happy to see the mortality rates decreasing for Indiana. I want to point out what you have access to within this data link, and this is risk of mortality and severity of illness for each of your sepsis patients. And why does this matter? Across the top bar, first of all, you've got how is your trend from quarter to quarter. Are you going up or down? And you can see in this example hospital, they went down in 2013 as far as their number of sepsis patients. up in fourth quarter 2018, then back down. So it's kind of a trend line with arrows there. But what I want to point out here is two things. This severity of illness and risk of mortality, you should have much higher numbers in the major and extreme categories for severity of illness and risk of mortality. One, for billing purposes. These are higher severity patients, and it makes a difference in your outcomes for your value-based purchasing when your case mix index is higher. Case mix is a factor of severity of illness and risk of mortality. I won't go into great detail there. But on the right, I want to point out what percentage of your patients had palliative care. Now, I'm aware that many hospitals don't have a palliative care team, but this is based on palliative care coding. And in this particular example, there was not a lot of palliative care being coded, except in first quarter of 2019 where there was one patient. So this is an opportunity to look at what patients have palliative care. And again, addressing end-of-life issues with our sepsis patients in a proactive way is extremely important. This particular page within Data Link shows your opportunity to benchmark against your coalition, the state, and your peer group. And you can take a look at these lines and see, am I higher or lower or about the same with your state, your coalition, and your peer group trending? Again, what are my opportunities for improvement around sepsis mortality? And you can toggle back and forth between ICD-10 or APR-DRG 720, and you can toggle between which peer group you have, but it shows you which peer group you're really in. You can pick the one that's relevant to you once you pick your hospital name. So take an opportunity to be aware of this data as well. Again, hurricane theme today. Don't let the hurricane catch you from behind without any forecasting. Hospital demographics. This particular page can help with your community awareness and your community outreach. It shows on the top left your point of origin for sepsis patients by quarter, and particularly where are your sepsis patients coming from. In this particular example, where it's darker in green, the majority of patients are coming from a non-healthcare facility, outside, likely home, and home health care. And so this is where the opportunity is. And the top right box shows what are your zip codes of your highest volume of sepsis patients for the last quarter for which we have data. And in this case, there's an opportunity in one particular zip code, probably two zip codes, to take a look at your ECFs in there, take a look at your communities. Where should we be doing our community awareness and outreach in order to identify these patients early and help them identify improvements in patient care from the host standpoint, individual patient care, as well as improvements from the environment and structures of care that can reduce sepsis. And also the other thing that falls into these points of origin is sepsis readmissions. Sepsis is actually the highest reason for patient readmissions. And where are your sepsis admissions coming from? Are these readmissions or are they admissions? And if they're readmissions, how can you reach out to make sure that you're doing day 2, 3 after follow-up discharge, making sure they're getting the services that they need? One example that was shared in a coalition meeting, and I'll say it was from Greene, is that Greene County, is that they noticed that their patients were primarily being admitted from home, readmitted. And what they found was if they refused home care services or home health initially, they may have figured out between day 3 and 7 after they got home of, oh my gosh, I really need some extra services. And by phone calls, they were able to implement those services and prevent that readmission for the patient who thought they were going to be doing fine when they got home, and they really weren't as good as they thought they were going to be. The bottom left on this graph is what your payer sources are for sepsis, and the bottom right is going to be very important for you to understand your patient population for that last quarter that we have data. What is the age distribution and frequency within these different age groups and mortalities? The teal is your overall volume, and the red at the bottom of that bottom right graph is what were the number of mortalities that you had within that age group. I'm a geriatric clinical nurse by background. I never think an age tells you all about the clinical condition of the patient, but it's not surprising to know that the majority of the deaths are in age 65 and over, but we need to be very aware of the deaths in the younger population and what are we doing to prevent those. And this actually, first quarter 2019 would have been flu season as well, so keep that in mind. lastly here is I pulled from that ART indicator dashboard within Data Link. This is particularly for PSI 13 postoperative sepsis, and it's another way to look at your data, comparing yourself by coalition or by peer group. At the top, you pick your hospital. On the top right, you can select between coalition or peer group, either one you want to benchmark against and see how your rate compares. And in this particular case, the hospital's overall post-op sepsis rate for the last 12 months, and again this is 12 months, was lower than the top 4 hospitals, but then there were many in the region. In this coalition there was 0. So this is a coalition comparison. Probably should have done it by peer group, but I'll leave that up to you to dig in. And if you don't have access to Data Link, your quality directors, your C-suite do have received information for access, and if you need it, talk to your quality director and have them contact our data services department so you can access, or at least sit down and go through some of these charts with those quality directors if you're a sepsis coordinator. So what further do we have for you? HIIN put out, as far as opportunities for improvement and resources. HIIN prepared 5 podcasts for Patient Sepsis Awareness Month. These, I've heard positive comments about these on fluid management, pre-hospital recognition treatment, the post-op sepsis improvement process called the SNAP, post-sepsis syndrome, and the future of sepsis. So I encourage you to go out and take a look at these particular podcasts on the hret-hin.org website. Under, you can get to it under topics and sepsis. So what is our goal here, and what do we leave you with? What are some opportunities to improve sepsis mortality? We want to see sepsis mortality continue to improve by improved care processes in a hospital, and we challenge you to some of these global opportunities. And I know you're all working on these, but accurate sepsis screening, identification, and treatment using serious criteria in the ED and in inpatient units. And again, I know you're working on the ED, the inpatient units is another opportunity that some have not quite got to yet. Accurate source documentation by the NDs, PAs, and APRNs, and that is to actually be able to identify your points within your sepsis bundle compliance to move forward. It makes it easier for the abstractors to find that data, and I know that hospitals are working with that to improve that source documentation to get accurate coding and accurate bundle compliance documentation. Some of them are saying that the best thing to do that is using standard order sets, that they get those antibiotics ordered in a timely manner, as well within 3 hours as expected, as well as the lactate and the repeat lactate and the blood cultures. Some are having difficulty documenting time 0 and are including that on their standard order set, so you have a starting point. Another opportunity is a sepsis flow sheet for bundle element compliance. It's really hard during the learning curve to use just your memory for identifying the bundle elements as you're trying to implement them. In hospitals who don't have a robust electronic medical record with a flow sheet available in there are using a paper flow sheet just to document on those individual patients when they perhaps do a code sepsis in the ED, and carry that documentation with the patient to the next transition of care if they're for communication purposes, but also to identify elements of the bundle that are still required. Another opportunity that we're hearing is positive is provider feedback around the bundle compliance elements. Oftentimes what happens in the ED, they leave the ED alive, but what happens if they didn't get the bundle met, or they need to have feedback of what happens with those particular patients and what happened along the way. So provider feedback seems to be one of the efforts that strong performing hospitals are doing in order to move towards that improved bundle compliance and reduced mortalities. I know that each of you have more items that you're working on. I encourage you to, if I've missed some things here, inevitably I have. It's a very, very complex process. Type it into the chat room right now if you think there's something that you're working on that is just hitting it out of the ballpark for other hospitals to improve sepsis mortality and improve bundle compliance. I just want to mention this is a marathon. I think that the sepsis compliance is one of the biggest changes that we've seen in our inpatient processes. I think it's because of, we always had the idea that something was going south on patients. They would not look quite right. Cognition would have been a little bit different. And now we think maybe there's a newer worsening infection that's occurring that we may not have thought of before. And now we have a direct intervention to do in order to save the patient from a newer worsening infection. So this is a marathon. We know New York has done a lot of work about sepsis. I didn't pull this slide for that reason, but let's all keep moving forward so we can continue to celebrate our successes around sepsis compliance. Yeah. Lastly, we do have, as of the last legislative process, a new bill about sepsis treatment guidelines in the legislature. And I'll mention a little bit, but I'm going to let Karen follow up here on this particular task force that has been created. And the goal is to adopt, implement, and periodically update evidence-based sepsis guidelines across the state. And there are several work groups within there. They're just getting started. And I think I'll let Karen comment a little bit about the work of that group that's just getting started.
Yeah, so thanks, Becky. So the Indiana State Department of Health has convened a statewide task force on sepsis. It's myself and Becky often attend, along with some others from IHA, really a good cross mix of different disciplines as well as settings attend these meetings. For instance, the Indiana State Medical Association attends the trade associations for the nursing home as well as home health. The Emergency Room Physicians Association for Indiana has 2 representatives who are just excellent. Actually, everyone is great on the work group. There are 2 consumers or patients and families that are represented on the group. There is a data component because part of this is that ISDH does have to make recommendations on data tracking and such. So Matt Brown has been representing us on a data task force related to this sepsis task force, and it's really actually so far, as Becky said, it's early on, but we're starting to make some progress, and I think everyone is just open and honest, that we really, ultimately, what we want to do is to reduce sepsis mortality in Indiana without creating burden, and really that's the big part of the task force and these subgroups is to research the evidence-based treatment guidelines, and that was something that we push for in this legislation, is that we want to make sure that whatever we do is evidence-based. In some settings, such as long-term care and home health, that there may not be necessarily that evidence base out there, but they can certainly pull from different settings and they can make those recommendations as appropriate. So is that anything else, Becky?
No, we have excellent participation. Some of the podcasts evolved out of the conversations that we were having there, and physicians volunteered to do the podcast as a result of our networking and collaboration that was occurring there. There were podcasts that occurred as a result of one of the sepsis work groups and one of the coalitions, and also out of that task force specifically. So I'm very optimistic then. And the people who are attending from the continuum of care are interested and eager to improve education to their staff out in extended care facilities, home health facilities, as they're represented there. So, and school nursing was represented there. So it's exciting, I think, without undue burden.
So here's, as always, we like to end with our contact information for the IHA team. I did want to introduce Catherine Bosma, who is here today, even though it's not necessarily a HIIN topic, but Catherine has joined us as our maternal and infant quality improvement advisor. So she is here with us in the room today, and certainly those who have OB services or just even pediatrics and you're caring for babies and moms, you will be getting to know Catherine over the course of the next several months and ongoing. So any questions or comments or anything in the chat, Becky? Casey?
No, but I can unmute.
Yeah, if you want to go ahead and unmute, and anyone, would like to speak up and talk about anything you're going to be doing for Sepsis Awareness Month, education, community outreach. I had mentioned the HIIN, extension, and that we'll be putting our plans together. If you have any feedback or suggestions regarding whether it be sepsis or another topic, we'd welcome that during this open period.
This is Beth Wallace, from Franciscan Health. And hi, I just have a question about palliative care and sepsis. I know when you were giving the rates, when you excluded the palliative population, that the percentages were much less. And I noted that with our own data. The problem that I have is with the exclusion of the palliative is you only have about a 6-hour window, I believe. They have to be placed on palliative care within 6 hours of admission. Otherwise, according to the EOM, you have to count those in your numbers. And so I feel like for hospital onset especially, we have such a low denominator that if, when we do count in our palliative population, it makes it a lot harder to move that number.
Of course, and there's some hospitals that don't have very large palliative care at all. And unless it's changed, I think it was palliative care within 3 hours of time zero excluded them from the bundle. Beth, you're absolutely right. But what happens is this palliative can get tagged on the end of the hospitalization when there was not the best care at the beginning. And so what I ask people to do is be aware of these palliative care patients and take a look at their processes that occurred along the way. If there were improvements that need to be done to address that palliative care, that's really the point of some of that is, are the patients being put on palliative care later, and including or excluding them from your perspective as you're looking at the data is up to you. I'm not sure I specifically answered your question, Beth, but palliative is an issue with that. And I just want to see hospitals taking a look at palliative as an intervention when they maybe missed key processes in the sepsis bundle early on.
Yeah. Well, I did audit about 6 months worth of charts to just look and see, and what I found was we did not initiate palliative. It's within the first 6 hours for the bundle, but we did initiate palliative somewhere after that 6-hour time frame. The problem, and I wanted to look to see if these patients were a failure to rescue, and what I found was that these patients really had multiple comorbidities, and really, from my perspective, we should have probably gotten them on palliative. It started that talk in the ED, but as you well know, oftentimes families are not ready to hear that, and not within the first 6 hours, especially if their loved one has gone into the ICU setting. And you have soft data as far as calling it sepsis at that point. It's hard for families to make that determination. And so what we're seeing is that it happens after that 6-hour point, but yet from our perspective from data, we don't look as good because we're counting those into our mortality based on the EOM.
The other thing is that also takes back to community awareness around advanced care planning. And one particular community was aware of the need for advanced care planning and did a lot of education. So by showing being moral, and I know that you all have done that as well, but if you've got places where your patients are coming in with sepsis, is there a need for advanced care planning to get them on palliative or other hospice prior to coming back into the ED so that those are addressed in advance, especially those highly complex patients who maybe just have avoided the conversation thus far. So I think that's another opportunity is advanced care planning in the community. And I do understand what you're saying, Beth. And so what are the implications of that? So thank you for bringing that up.
Thank you, Becky.
You continue to challenge my mind. Thank you, Beth, as always. Any other questions, comments? We welcome them. a good conversation to have. In the weeds with me, Beth. Any comments in the chat room?
Nope, nope. Just, again, hearing that more people are receiving their packets of goodies, so keep an eye out for those as they should be arriving, and we want to see how you use them. So please send me that stuff, post on social media so we can get the word out.
And if you need any help drilling down into your specific hospital's sepsis data, give me a email or call or whatever, and I'll help you dig a little deeper on your own. All right, thank you very much for attending our HIIN monthly call today, and we appreciate all of us, and all of our shining faces are here in the room, in addition in the picture that you have in front of you. We appreciate your support so much, and we look forward to working with you on this next HIIN extension contract. Good day to you, and happy hurricane watching.